Good afternoon, everybody. Thanks for joining. Seven people joined so far, but it's only 2 minutes past midday. So we'll just, as usual, give people a couple of minutes just to log on in case there's any technical issues.
James, can you hear me?
Oh, yeah. Hi, Merle. Yeah.
When I went into the link in my calendar, I had to copy and paste the Zoom location link into my browser to do it that way. So now my camera doesn't seem to be working, which is fine. But I'm just wondering if other people might be having a technical issue with that too.
Oh, I'm sorry about that. Okay.
Yeah, Merrily Blair here. I had to do the same. I had to copy and paste, and then I could turn it into a hyperlink, and away we went.
Yeah.
Oh, yeah, I see that. I'm just looking at it now. It won't. It's not a hyperlink. It's just plain text, isn't it?
Hopefully, I'll figure that out too.
Yeah, I will. Should be able to put the hyperlink in the main body. We'll do that for next time. Thanks for letting me know about that.
No worries. Maybe.
So just while we're waiting for the last minute or so, if you could put in the chat just a little poll. So on a scale of 1 to 10, how much error and harm do you see in your work area? So 1 being not at all, 10 being all the time. That's great. We're getting some 5s, some 4s, some 3s. That's good. Merrily saying minor 7, potentially major 3. That's great. Okay, yeah. For me, what I see is probably a 3. But if I was to properly look every day, look under the carpet, so to speak, I think I could probably make a 10. Don't know about everybody else, but I think there's probably a lot of unnoticed harm and error occurring on a daily basis in our organization. Right, so I'm just going to share my screen. Here we go. And I just want to that. Okay, we are recording, so if you don't want to be on the recording, you can mute yourself and turn your camera off. But it's just so that people who couldn't make it can catch up later. So just give me a thumbs up if you can see that screen. Great. So the topic is error and harm, and it goes along with module PS 102. Hang on. No, it's not. It should be a QI 102. Hang on. Let me just get the right one up. Sorry about that. Okay, I hope you can see the right presentation this time, which is basic improvement methodology. So yeah, this goes along with the module QI 102, which suggested that you're looking at this month. But of course, you can do these modules in any sort of order. They're fairly standalone. You can bash through them all together, or you can save up a bit of study time for them and do them in batches, or you can kind of like just come along for the ride with the suggested schedule. So this is the main thing that we're looking at today, and this is called the model for improvement, and it's been around for probably around about 15 years, and it's probably one of the most popular models in healthcare for improvement. There are so many. In fact, a few years ago, there was a great Twitter campaign on Improvement Methodology Olympics, and Helen Bevan put up 50 different improvement methodologies and put them head to head, and people voted week by week. And eventually what won at the end of the day was Model for Improvement. So it's good to know the IHI are still promoting probably the most popular one. And the reason it's popular is because it's simple, it's easy to understand, and a lot of people already are familiar with it. So that's the one that I generally tend to reach for, but it's worth knowing that there are other models out there, and sometimes a different model might suit your project better. For example, if you're doing large scale change across a nation or a large, say the South Island, then it may be that a Plan, Do, Study, Act model just doesn't really work. For example, in London, they implemented a stroke network. So all the hospitals changed the way they delivered acute stroke care. And really, it was too difficult to do that in this model. And so they use a different way. Anyway, so this is what we're doing. When you're thinking about how we can improve, there's always three sort of main things that you need, ingredients. One is the will to improve. Somebody needs to want it to change. If nobody wants it, then nothing will happen. Two, you need ideas, because you can't keep doing the same thing and get different results. That's the definition of insanity. And then number three is execution. It's got to actually be done in order for it to happen. So it's kind of stating the obvious, but it's also a good way of reassuring yourself that making change is difficult, because these three things are difficult. And if one of these things is just never going to happen, say, for example, nobody is ever going to want to improve, then there's no point in carrying on with your change idea. You have permission to ditch it. So the execution part of this is Model for Improvement is the method. So as I said, there's lots of improvement methods, and the other ones may be Lean and Six Sigma, and those ones have kind of come out of Toyota. And it's not necessarily what you choose, it's just the fact that you are choosing one that everybody understands, and everybody then speaks the same language and pulls in the same direction. So it's about having the same framework. So it's 3 questions and then a cycle. And these are really powerful questions. I think it was Tony Robbins who said, the quality of your life is determined by the quality of your questions. Well, in quality improvement, it's the quality of a project is determined by the quality of your questions. And these are 3 really good ones to start off with. So what are we trying to accomplish? How will we know change is an improvement? And what change can we make that will result in an improvement? So for the first question is about setting an aim. It's about setting how good are we going to make things, or how much better are we going to make things? Okay, what are we trying to do? What is the population? Can we draw a circle around the people that we are trying to improve lives of? And by when? Time limited. So this is pretty much, if you're going to write out an objective, you would be using a SMART framework, SMART, which is specific, measurable, achievable, realistic, and time-bound. You probably heard that acronym before quite a lot. Here you go. Specific, measurable, achievable, ambitious. So, I mean, there's no point putting an objective out there which is so easily done that you could do it without much effort. Then that's really a waste of time. At the same time, you don't want to be over ambitious where you're never going to achieve it, because then it's always seen as a failure, even if you did make good ground. So be ambitious. It also motivates people if there is an ambitious target. You know, if there's something that makes people excited, but at the same time not put off, then that is the sweet spot you want to achieve. So a little vote on the chat. There's two statements here. Which one do you think is better if you put 1 or 2 in the chat? So number 1, reduce all types of hospital-acquired infections by as much as possible, as quickly as possible. Or number 2, decrease the rate of hospital-acquired pneumonia for patients in the ICU from 23 infections per 1,000 catheter days to less than 5 infections per 1,000 catheter days by May the 1st. So it's unanimously number 2. Yes, I agree as well. That's because, oh, I skipped too quickly. It's specific. So we're talking about hospital-acquired pneumonia, which has a good definition. It's measurable. So we're talking about infections, which we can measure. It's difficult to measure infections, actually, but there is a good way to measure it. It's ambitious. So the drop there is significant, from 23 down to 5. That's a five-fold, almost a 5-fold reduction. That is really quite a lot, but I think it's probably achievable considering the scientific literature we know. It's realistic, and it's time bound, so by May the 1st. So for the second question in this model for improvement, how will we know changes in improvement? So this is really asking, you know, what are we going to measure to prove that what we've done has changed things? And people always initially gravitate towards data, which is, you know, quantitative, and often people think about what the computer has, you know, in terms of what we got on our databases and how we get at it. And then that triggers you an email to digital support saying, can we get some data on XYZ, followed by about 6 months of silence. So this is where people trip up all the time. And this is where projects never get going as a result. So the trick here is to not think so narrow about your data. The trick is to actually think about all sorts of ways in which you could get just enough data to answer your question, or at least to get you going. And so there is other types of data. There's qualitative data, which is, I know, a lot of talking to people. Might take you a bit of time, but it'll take less than 6 months, that's for sure. There is manual data collection, which is a bit of a hassle, and again involves manpower or woman power, but again takes a lot less than 6 months. And often what you get back after 6 months from digital support is not quite what you want to answer your question anyway. And there's usually caveats or secondary questions. And so 6 months becomes a year, becomes 2 years, becomes never. So that's a little summary on that. When we go into data a bit more in the next few modules. So that's it. But the measures that you really want to create are in 3 types of measures. And it's really important to focus on collecting all 3 different types of measures. So can anybody tell me what the difference between an outcome, a process, and a balancing measure might be? If you don't want to chat, you could probably put something in the comments if you wanted to.
The difference between them.
Yeah.
Did you ask?
Or just explain what they
Oh.
are. Yeah, then that way you will be explaining the difference. Elvira says outcome is the final result. Process is to get to the result, and balancing is make changes in process to get to outcome. Okay, I agree with your first two there. Yeah. So yeah, so outcome measures is usually the final reason why you're doing it. So an outcome measure in the previous example would be the infection rate. And one way you can think about it is, does this mean something to the patient? If the patient was to get an infection or not to get an infection, would they care? Yes, they would. So that is probably an outcome measure. And the best outcome measures are patient-centered outcome measures, ones that the patient really cares about. Process measures are things that may indicate you are getting to your outcome. So a process measure in the last example might be the use of a standardized protocol for putting in catheters, for intravenous catheters, for example. So if somebody was compliant with that, then you would expect the outcome to drop, the infection rate to drop. The process measure itself is not what we're trying to achieve, but it is something that if we do it on, we will get to our outcome. It's also less interesting for the patient. The patient doesn't really care whether you followed the protocol or not. They just want a good outcome. Balancing measures are measures which are unintended consequences, basically. So you want to think about what might happen that you didn't want to happen as a result of your change. You might even predict that it will happen, but it's an acceptable balancing measure. So if you instituted a change in the way your visiting hours were done, a balancing measure might be number of complaints. For example, you might monitor the complaints against and see if that has gone up as a result of restricting visiting hours, which it probably would do. So another way to summarize these things is outcome measures is where are we going? Process, what are we doing? And balancing, what else is happening? So here's a little quiz. Put your answers down on the chat. 1, 2, 3, balancing, outcome, or process for each one. So the first one is average number of times patients receive recommended oral care in 24 hours. Number 2, patient and staff satisfaction scores. Number 3, rate of hospital-acquired pneumonia per 1,000 catheter days. That's okay, Marilee. Number 1 is an oops measure. Just joking. Okay, Claire says outcome, but maybe you mean that for the first one. Rainey says the first one is a process measure. Any more answers? Give you a couple more. Okay, here we go. Blair says 1 is process, 2 is balancing, 3 is outcome. Marilee, outcome measure. 1 is outcome, 2 is something, and 3 is balancing. Rainey says 2 is balancing. Kelsey says process, balancing, outcome. Okay, so we got a bit of a consensus, process, balancing, outcome. Let's see if we're right. Yeah, process, balancing, outcome. So the reason the first one is a process outcome is that I mean, you do need to make an assumption about why they're doing it, but if you know a little bit about ICU, for example, the reason why we do oral care is to prevent respiratory tract infections and ventilator-associated infections. Or if you do it on the ward, you're probably just trying to prevent dental disease. So the outcome in that case is actually, you know, dental disease or ventilator-associated infections. It's not the oral care itself. There's probably one example where oral care itself would be the outcome, and then that is if the patients feel better, their teeth feel better having it cleaned. So that is the outcome. It's like, does your mouth feel better? So it might be the outcome measure in that case, but most of the time it's a process measure. We're doing it to achieve an outcome. The second one is balancing. So yeah, that's where we can find if whatever we're changing has having an adverse effect on the satisfaction of our patient or staff. And then number 3 is the outcome. Yeah, so it's quite clear that what we want to achieve is reducing hospital-acquired pneumonia. Okay, so step 3 is the third question: what change can we make that will result in an improvement? So it's basically saying, what are we going to do to make it better? Okay, and there are many different things that we can do to get these ideas flowing. There's process analysis tools, there's benchmarking, there's technological solutions, there's creative thinking, which is some techniques you use with groups to come up with wonderful, wacky ideas, and there's other types of change concepts. The main thing is that you can't develop a change on your own. You're not going to come up with the right solution if just one person decides it. And the reason that is true is to do with the old elephant in the room situation. So in this metaphor, you have an elephant in the room, and you got 4 people in the room with blindfolds on, and you ask them to tell you what's in the room. And one of them is holding the tail, one of them is holding the trunk, one of them is holding an ear, one of them is holding a foot. They all have different perspectives. They all can feel different parts of the elephant. And so they come up with different conclusions based on the different body parts they're holding. None of them come up with the correct answer, but all of them have a part of the answer. So it's the same with a problem in healthcare. Everybody has their own perspective, and they have what they see is true, but they don't see the whole picture. So in order to have a solution that is going to address the whole picture, you need to get ideas from everybody, or as many people as possible. So change concepts include these sorts of categories of things. And this is a good, actually, checklist to use with the brainstorming session. So if you're holding a brainstorming session with 10 people in a room and you're asking them to generate ideas, a blank sheet of paper can lead to a lot of silence. So using lists like this can help stimulate ideas. So things like eliminating waste, improving workflow, optimizing inventory, enhancing the producer-customer relationship, changing the work environment, managing time, managing variation. That's a really good one. Design systems to prevent errors. That's a great one too. Is used a lot in healthcare. Focusing on the design of products and services, and that kind of tends to happen way upstream from us, you know, in terms of medical product design and when you're designing services before they're actually running and stuff like that. So there's lots of ways in which you can generate ideas. Can you think of other ideas that would improve oral care in ICU? So in terms of improving workflow, for example, you could ensure that the mouth cleaning supplies are kept in a ready-to-go state. So that reduces the barrier for a staff to complete oral health care. optimize the inventory. So make sure that we have enough of the stuff we need all the time. And that's easier said than done, isn't it? Because sometimes we go to the cupboard and suddenly it's bare, and we realize that the person who was there last forgot to order it. So there is actually techniques we could do to prevent that situation happening, because that's actually relying on a human to complete a task, and there's human error involved when they forgot to do it. So is there a way we can systematize to get around that human factor? And there's something called visual management, which is where you can have a very tidy cupboard or in a stock room where you can stand in the middle and you can instantly see where the low stock is. And then you just need a system where you have a routine audit. Somebody goes, stands in the room, ticks off the things that need ordering and go away and does it. So that kind of reduces the error of forgetting to order stuff. Changing the work environment. So train hospital staff on proper mouth cleaning technique and importance. It's actually interesting that training is fairly low impact intervention. You would think that training is great, that if people go through training, they're going to do the right thing. It just doesn't happen. And also the other thing is that actually trying to train 100% of your staff is like herding cats. It's an endless task because your staff come and go all the time. Managing variation. So changing the guidelines and updating them to make them consistent with national guidelines helps, so that new people coming in are going to do the right thing because it's in line with what is done in most other places, for example. Another great way to manage variation is to actually audit your protocols. So if you got a protocol of how to do something, then the next thing to do is to measure, okay, how often are people doing what is said on that protocol? And how often is there a variance to that protocol? A lot of people talk about protocol compliance, but I actually don't like this in healthcare, because it suggests that the healthcare professional is being deviant and is doing the wrong thing. And of course they're not. Everybody comes to work to do the best job that they can. And we're all professionals, and actually we make 10,000 decisions a day. And all the decisions we make are based on the environment we find ourselves in the first place. So if somebody violates a protocol or varies from a protocol, it's probably for a really good reason. It might be because there were no supplies, or it might be because they weren't trained, or it might be because they actually thought that there was a better way to do it. So protocol variation is a great thing to measure. And some of the signs from that suggest that probably for clinical pathways, where you're treating somebody according to a certain protocol, 20% variation is probably where it should sit. If you have less variation, then your protocol is too strictly applied. It's not allowing for tailoring the situation to the individual in front of you. If the protocol is, if the variation is more than 20%, then there is a problem with enforcing it or encouraging people to follow it. It varies from protocol to protocol, and you need to sort of do a series of quality improvement cycles before you really find out what probably for that protocol the right variation should be. But then once you got to that level, then it's simply a case of monitoring the variation. And if it changes, then looking into it and why has it changed? Maybe there's a new national protocol that's come out and then you need to change your guidelines, for example. So protocols are really, really interesting. And often they're just written, put out there and forgotten about, but they're actually much better if they're used as a live sort of living document. Designing systems to prevent errors. So post the oral care protocol in visible places. So that's again, trying to encourage people to follow the right steps. Then step 4 is this circle underneath. It's called PDSA. And it's called Plan, Do, Study, Act because it that's what you do. It's very similar to an audit cycle, but the main difference with an audit cycle is that audit starts study, act, plan, do. So audit is really focused around just measuring what we're doing now. And then on the end it's tacked, okay, now go do something about it. And there is no framework at all within clinical audit to actually achieve any meaningful change. And as a result, a lot of clinical audit doesn't result in any meaningful change. But it does kind of point us to where the problems are. So plan, do, study, act is very, very similar, really. It's still about measuring something against the standard and then deciding what to do, and then studying what happened and then repeating it. But it's a much more focused on actually achieving a change rather than getting a good body of data to work from. In clinical audit, you tend to audit quite a lot of data in order to get a really good picture. In quality improvement, you just need enough data to say, okay, we need to do something about it. In quantitative data, that would be roughly about 30 data points, which is not a lot. So the plan section would be questions and predictions, what are we going to do? Who do we need to involve? Where are we going to test this? When are we going to test it? How are we going to measure all the data? Have we got our baseline data ready? How are we going to measure data during and after our testing? In the do section, this is where we do our tests. So typically what you want to do for your first PDSA cycle is the smallest unit of test you can think of. So that might be one patient, or it might be one shift, or it might be one team. The whole idea is you've got to make the unit of testing so small that it is not daunting at all. It seems too easy. It seems like something that we could just do tomorrow. And that's exactly what you want. You want to be able to do something so easy, and that gains momentum quite quickly. So a big mistake that people make is thinking about their first test is far too big. The other thing is that they try and make it all perfect before they start testing. And that's also the wrong thing to do. You want to just get going with your idea as soon as possible, accepting that there's going to be lots of things that are wrong about it. But there are two approaches to quality improvement. One is to focus on everything that is wrong, and one is to focus on everything that is right. And probably the best is somewhere in between. But a lot of the time we forget about focusing on what is working. And that's meaning we're losing at least 50% of the opportunities. So by doing an early PDSA, not only are you finding out what didn't work, but you're also finding out what does work. And where the enthusiasm is, where the open doors are that you can push on, what is going to work. If you just put more resource behind that, that's going to amplify your success. So start off with a very small unit of test. Okay, observe the results, document the results, and share it amongst all the stakeholders to gain support and enthusiasm for it. You'll be surprised at just how many people are so delighted and excited that your first little test worked, and it will generate a lot more discussion. And for your next one, people will be behind it more, which will be more difficult because it'll be a bigger test unit. So yeah, you draw out the results, you analyze them. Usually you use a run chart or something like that if it's quantitative data, and then you act. You refine the change and you plan for the next cycle. And it's usually good to try and get the next cycle going before the memories fade, so you have people remembering what happened previously. In my previous PDSA cycles, one thing that I've used quite effectively is little videos to communicate the results. And the best video is one that involves a patient as well. So if you can get consent from the patient who is in this PDSA cycle to do a little 10-second soundbite on the video for you afterwards, you circulate that, you will get so many people watching it, and you get a lot of excitement. So as I said, you don't just do one cycle, you start with the smallest, you start small, and then you think about building it up and making it happen. And as I said, don't wait to begin. You got to get going sooner rather than getting it perfect. So in summary, you set an aim, you establish your measures, you identify the things you're going to do, you test your changes, and then you implement the change once you've got your final blueprint. So now I'm going to share a bit of a wacky video with you. I hope the computer sound comes out. If it doesn't, give me a wave and I will try and fix it. Okay. Oh, hang on. I think I'm going to need to do this. Hang on. Okay, you should see Institute for Healthcare Improvement Open School. Yep, great. Thanks, Blair.
I'm going to talk to you today about Plan, Do, Study, Act cycles, commonly known as PDSA cycles. So let's just go over for a second what those terms mean. And I'll start by telling you that this is a method we use in science, we use it in everyday life, and we certainly use it in improving healthcare. So plan, by plan we mean we're going to run an experiment. We have a hypothesis, we're making a prediction about what will happen when we run this experiment, and we're going to determine whether or not that prediction holds up. That's where the do comes in. We run the experiment and then we study, that's the S. We see whether or not our prediction was in fact verified when we acted on our plan. Based on what we find, on the data we get from the PDS, we then revise our plan if necessary and act to change our plan and have another hypothesis and run another experiment. So that's pretty simple, and you'll probably seen many examples of this in healthcare, even if nobody called it a PDSA. Let's look at an example of trying to prevent central venous catheter-associated bloodstream infections, or CLABSIs. Now, we all know that a checklist has been shown to be very effective in getting folks to reliably do the right evidence-based practices when they put in a line, and that reduces infection. The question is, how do you actually get that done in practice? How do you execute on that evidence-based plan? Well, we know that among the things you're supposed to do when you put in a central venous catheter are to prep the skin with a certain kind of antiseptic, it's chlorhexidine, and to use a large surgical drape. Those are two of the elements of the checklist. The question is, how do you get them to be at the bedside reliably so that the care team has them at their beck and call when they're ready to put in the catheter? So the physician's ready to put in the catheter, and you have a theory that if you include the surgical drape and the antiseptic in the packet of supplies that the team brings to the bedside, the physician will always be able to do it. He won't have to be looking all over. She won't have to be hunting for these supplies. And that's your theory, and you predict this will improve care. So you do that experiment, and lo and behold, not surprisingly probably, the drape is there, the antiseptic is there, the physician uses them when he puts in the catheter, and infection's probably less likely. That's a PDSA cycle in healthcare. So I know you're dying to try this in healthcare, and that's great, but I recommend that first you try it in your own personal life so you get comfortable with it, so that when you go to healthcare, you'll feel like, I've done this before, this isn't that hard. But I'm going to talk about, of all things, cucumbers. And I care about vegetables. I have raised beds. I spend a lot of time and effort. I don't want stuff to go wrong. So this year I decided I'm going to plant cucumbers and prepared the soil, put in the fertilizer, dropped in the seeds, 3 seeds to a hill. They sprouted. I thinned them to 1. Things growing like crazy. And I running it along my bed and looking at it with admiration. I come back from work to home, and I see that it's been chopped off by a weed whacker. Turns out every Monday there's a guy that comes and he does our lawn, right? And he has a weed whacker and he chopped off my cucumber. And this results in a pretty stunted cucumber. So I said, well, look, I have a theory that if I prop this cucumber vine up on the raised bed more carefully, the weed whacker won't get to it. That's my prediction. And so I put the cucumber vine up on the raised bed, came back. By golly, the head was chopped off again. My prediction was not correct. When I studied the result, it was a disaster for my poor cucumber. And so I had to revise my plan. I had to act in a different way. My next experiment was to put a large flower pot in front of the cucumber vine, hoping that the guy with the weed whacker would understand that he wasn't supposed to meddle with this thing. And lo and behold, I come back, another PDSA cycle failed, and he'd been mangling my cucumber again. At this point, I actually thought about something that you probably use in your life, and we certainly sometimes default to in healthcare, and that's called brute force. I went to find the guy, the weed whacker guy, and basically grab him by the shoulders and shake him and saying, "You're killing my cucumber." But I restrained myself. This is improvement. We don't want to have blame. We want to do things better and make things better for the weed whacker guy as well as myself. So my next PDSA cycle was to put the cucumber up on a trellis. I figured if I had a trellis, and I have a very pretty one, as you can see, it's in the shape of a leaf. It's really quite attractive. I propped the cucumber up on that so that a weed whacker really couldn't reach it. And lo and behold, look at it, it thrived. My prediction was get the thing out of the way so that the weed whacker absolutely can't get to it. This is called a forcing function. The forcing function is the darn weed whacker just won't get that high. He can't do it. And my cucumber's thriving, and I'm telling you, I had the best marinated cucumbers, a little onion, salt and vinegar last night, just like my mom used to make it. This was a really good PDSA cycle. So that's all there is to it. You can do that in your own life. You can do it in healthcare. Remember, you have to have a prediction. You have to start with a theory. Your job is to see whether or not your theory is a good theory. Most of our theories, we have some doubt, so go test it. Run a PDSA.
Right. So hope everybody using PDSA cycles in their garden soon. Well, let me just stop YouTube. Okay, so so here we go. We're gonna design our own QI project just in the last 10 minutes. I'm going to actually put you into 2 breakout rooms so you can actually do a little chatting amongst yourself for 5 minutes, just 5 minutes, and then we'll come back and talk amongst the group. Just you're not going to get through the whole model for improvement. That takes a lot of work. But it might be fun just to first of all think about things that might be good for a small QI project, either in your home area or in your work area. I don't mind, but just thinking about small ones. I don't want you to think about big ones. I want you to think about small ones, so you could actually then imagine how it might be possible to go through the rest of the model for improvement for those things. But we're probably just going to focus on the first question: what would you try and accomplish? So I'm just going to create these little breakout rooms, and the breakout rooms are going to close automatically after 5 minutes. Okay. There we go.
Too much stuff. Too much stuff.
So it's cluttered.
Just
Yeah.
checking you guys are okay in here.
Yes, thanks.
See, great. Okay.
Thanks.
to that facility. So I don't know how you would study whether that facility was
Just yep, we got 10 back in the room. That's great. Good. So I hope you had a little fun with some ideas. Maybe if one or two people could share some ideas that they heard or they suggested.
I'm happy to speak about what our group talked about.
Yeah, thanks, Jill.
We started off with the kitchen pantry having too much stuff in it.
Oh, yeah.
So we just were very general and talked about the pantry being too cluttered and how we wanted to improve the look and accessibility. So we then decided to start thinking about how the cluttered look happened. So we were thinking about who would access the pantry, who does the shopping and puts the items away, who uses the pantry, and came up with a possible problem that there's one main person that uses it that has the problem with the pantry, and potentially it's another person that's doing the shopping and putting things away. So we also thought about perhaps when the shopping is occurring, too much stuff is being bought, which would result in an overstock of the pantry. So then we moved on to thinking about how we would want to improve it. So we would probably look to how we want to categorize, look at use by dates, quantity, placement of high use goods over low use goods. And the bit that we were then moving to but didn't fully get to was how we'd have a quantifiable outcome.
Very good.
But that's where we got
Excellent.
to.
Yeah, well, I mean, I guess one good outcome would be less waste, you know, I guess if things are being thrown out or not being used, then because actually the same thing definitely can happen for a clinical area. So if you go into a store cupboard and you did an audit there, I bet you could find maybe $20,000 worth of stuff in one cupboard that is either expired or never used, etc. So you can have a dollars outcome on that thing. So actually your example is a brilliant one. Thank you very much. Did the other group want to share their idea? Well, that's okay if you don't want to. One other thing that sprung to mind with your idea, Jill, was it works really well with Lean and Six Sigma. That's that sort of idea. One of the tools in there is called, as I mentioned before, visual management, which is, you might see it on some of the wards now, is where if you want something to always look like a certain thing, like the inside of a cupboard has the biscuits here and the cups here and stuff. What you do is you take a picture of it in the proper state, and you print that picture and you stick it on the outside of the cupboard. And then whoever's going into the cupboard knows where to find stuff. Whoever's stocking the cupboard knows where to stock the stuff. And it's instantly clear if this has been overstocked, if it's understocked, if things are in the wrong place, because it doesn't match the picture. On the ward, you might have a specific place for a Dynamap, for example. Some people just take a picture of it in the right place and then put that picture on the wall. Or we've got little stickers on the floor as well, which is a bit more high tech. But I mean, you can get real low tech about it. You just put a little picture up. The same goes with a meeting room, which you come in and multiple people use a meeting room, and it needs to be laid out in a certain way for it to be functional. And of course, people move the tables and chairs around sometimes because they're doing something else. But if there was a picture of that room in the right state and a little poster on the wall saying, if you move everything around, make it look like this before you leave, it does help a little bit. So so that's a little tip, visual management. But again, looking at waste, so pulling out everything and then totaling up the dollar value of the stuff that's just never used or out of date and stuff like that is a good way to quantify your outcomes. Good. Any further comments on that idea or any questions about the content that we covered? Wonderful. Well, I hope you have a wonderful Friday and the rest of the weekend. And thanks very much for joining us. Take care.